Hi there, good morning everybody. Looks like nobody else has joined us. So, oh look, there's Christy joining us now. So welcome to our pain management clinic for this morning. Thanks for being here. We'll start off with introductions of everybody. So I'm Troy Jorgensen. I'm the program manager here for Project Echo Nevada.
I'm Michael Lewandowski. I have a PhD in psychology. My subspecialty is pain management, and I've been doing this work for probably the last 36 years. I'm on the kind of assistant clinical professor at the School of Medicine, Department of Psychiatry. I've been doing that for a number of years, helping first, second year med students with just pain management, and also an adjunct for the clinical psych department here at the university. So it's nice to be here. And to my right.
Hi, I'm Paul. I'm a course director at the University of Nevada, Reno School of Medicine. I specialize in addiction, substance use, and mental health disorders. Troy.
Oh, I already went. Go ahead, Sneha.
Hi, I'm Sneha Sharma. I'm the program coordinator for Project Echo Nevada.
All right, Alan, do you want to go ahead?
Yes, I'm Alan Fisk out in Elko. I do technical support around about. Need some help, let Troy or myself know.
Thanks, Alan. Next is Dr. David Bayan. Dr. Bayan, please go ahead.
I'm David Bayan. This week I'm at the VA. I got a lot of injured folks and anxious folks.
Thanks for being here, Dr. Bayan. Any cases for us today that you want to chat about?
I do not. Sorry about that.
No problem. Thanks for being here. We'll move on to Jake Lewis. Jake, are you there? Could you introduce yourself, please?
Yes, my name is Jake Lewis. I'm a PA out in Lovelock Clinic.
Thanks, Jake. Good to have you. Any cases you want to run by the team today?
Sure. Should I do that now or?
Let's finish up introductions and then we can get into that with you. Yeah.
Okay.
Thanks. Christy Somson, please go ahead.
Yeah, I'm Christy. I'm a PA in Wendover.
Thanks, Christy. Good to have you today. Any cases for the team today?
Not anything in particular. We just have a lot of problems with access to like pain management, people getting out of town to go to that. So, just looking for any kind of ideas, I guess.
Gotcha. Yeah, happy to have you here and happy to help. And then last is Dr. David Dalton. Dr. Dalton, are you there?
I am here. Howdy. I'm David Dalton. I'm in Caliente, Nevada.
Thanks, Dr. Dalton. Always great to have you.
Troy, what should we do?
I think we can squeeze in your talk.
Okay. All right, good. Yeah, let me go ahead and blast through this and tell a story, the anxiety and fear of re-injury story. So let's see here.
Real quick, just a reminder that we do record all these sessions. We do cut out any of the portion of the session where we discuss the cases, though, so it's only going to be this didactic portion of it. But if you don't want to be on video, just let us know and we can edit you out.
So our whole goal here for ECHO is to kind of talk about pain management and an interdisciplinary approach, which is really what we're doing right now. Here we have different disciplines talking, communicating about cases. So that's our goal. Disclosure statements, our background. Okay, so learning objective. Real quickly, I just wanted to talk about, why should I encourage you to look at anxiety and fears of re-injury? What's the reason? And what are the risk factors for people? And discuss real quickly concepts of hurt doesn't mean harm, and how that plays into anxiety. The idea that if I'm hurting, I shouldn't do anything. I should stop. I should avoid things. I should sit in the corner. It's suggesting that I'm going to harm myself. There's a huge distinction between those, and psychologically it's critical because if people believe that they've harmed themselves, they're not willing to do much of anything. So I wanted to just talk about that and attitudes and beliefs and some of the other issues that I think tie into this fear avoidance model of pain, which I think is very powerful. And maybe even talk about some screening tools. So I love this. So algology. Dr. Cole was on earlier, and one of my mentors, besides Dr. Cole, was also Dr. Richard Weiner, Richard Weiner, plus also Dr. Cronin. And when I first met Dr. Cronin, Dick said that he called himself an algologist. And at the time, you know, I'm a graduate student, and I thought, okay, now oncologist, does he study algae? What does he do? Or is it some type of this is a mining state, is he interested in some type of minerals, you know, mining, a gem or something? But algology is actually pain. So he was an algologist. He referred to himself that way. And really, algophobia is a fear of pain. And I think it's a really important concept, thus this topic, in terms of the patients you see on a day-to-day basis. How fearful of pain is this person? And I would suggest that if they're very fearful, then there's a set of things that we need to take a look at, or we could look at, to possibly help divert them from a path towards disability and dysfunction, and one of possible recovery and improvement. So why examine fears of re-injury? Well, and anxiety. These things can lead to avoidance strategies for living with pain. And the biggest thing that I've seen over my career is that movement is life. Trying to keep people moving when they have a pain condition can be challenging because of these factors. When people stop moving, when people start using avoidance as a major strategy, we now move from what could be more of an acute rehab to a chronic problem, persistent pain. It leads to deconditioning. There was an entire paper, I don't know if any of you, the name Gordon Waddell and Walter Bortz. I think Walter Bortz wrote a paper on the deconditioning syndrome. It's a fabulous paper, and I encourage you to get it. I'll give it to Troy so you can get it off of the Echo. And it just talks about all the problems that occur when people stop moving. Physiologically, some of the reasons. So this could be used as a motivator to get people to look at slowly start re-energizing themselves. A lot of research shows that anxiety and fears of re-injury are really one of the greatest factors that perpetuates and maintains disability, dysfunction, and pain. So I think that's an important issue. I have a bunch of slides. So that's why this is important. And I like to draw your attention to the second point. Fears of re-injury and avoidance behaviors are 7 times more powerful, 7 times, than any clinical or historical data that predicts pain 1 year after a low back injury. So very potent, powerful things to be looking at. And I come back to a statement earlier. How do you assess? Well, I'm curious. I'll throw this out to the group. Currently, do you guys look at anxiety? Do you look at the concept of fears of re-injury in the patients you see who have persistent pain? Does anybody like to jump in on that? Do you even attend to that issue? Forget the fact that I think you should, but how do any of you assess the anxiety or avoidance behaviors in the patients you see? Anybody willing to jump in there?
Yeah, anybody want to jump on that question? Feel free to unmute yourself with the little microphone icon on the Zoom toolbar, or write in through the chat box, please.
Hello, Dr. Koss.
I mean, I do ask him about this, but
Excellent.
I don't have any special thing I do.
Okay.
I encourage him, hey, you still need to increase your activity because I want you to be acting and performing like you did before injuries.
Excellent. Excellent. So I'll share with you what I do. Again, I've mentioned this a couple times already today, so I'm kind of beating the point, but I'll simply ask somebody on a 0 to 10 scale, how anxious and worried are you that you're about your pain problem? And typically what I hear is, oh, I'm a 9. And so then I'll gently ask them, rather than say the word why, which may make some people defensive, I say, well, I'm curious, what makes it a 9 and not a 3? Now I get them saying, well, you know, my cousin Louis actually had similar kinds of pain, and you know, it turned out that he ended up having cancer and then he died. And so now we're getting at some beliefs and some values or some concerns about anxiety that's more personal for them. You can also go the other direction. If they say it's a 9, I gently ask people, I'm curious, what do you think would make it a 10? Make it even worse? And they may say, well, boy, I'm really worried. The doctor told me that if I did anything, twisted the wrong way, or if I ever got in another car crash, I'd be paralyzed from the neck down. So man, I don't want to get in cars. I don't take long trips. So you can see, you can begin to get an idea of what's kind of perpetuating and possibly maintaining some of this pain problem through these emotional channels. So found that to be helpful. Okay. So yeah, here's Gordon Waddell. You know, the fear of pain, just the fear of it, and what we do about it is more disabling than the pain itself. These are some wonderful quotes that I've come across. Fear of re-injury by activity was a better predictor of self-reported disability than any biomedical signs. So, you know, again, bless you guys, on the medical front, you don't have a lot of time to deal with patients. We do, Paul and I do, so these are the things that we have an opportunity to explore a little deeper. But I just want you to make you aware of some of these issues and maybe how you could gently, you know, maybe just on the surface get into it. So the biggest issue with anxiety is we talked about catastrophizing in the past. The idea that it's an extreme negative evaluation. Statements like, this is awful, this is terrible, I can't handle this, this is too much. If you hear those kinds of statements, you probably are going to see high levels of self-reported anxiety. And I've often said anxiety is like gasoline on the fire of pain. It just makes it worse. So anything we can do to kind of dig deeper and do this data mining of what's going on in this person's head, what are they thinking about their pain, and where does depression, anxiety, anger, frustration come in? And what it does, again, is if it leads to escape or avoidance behaviors in anticipation of pain, we've got somebody now who's not moving. And I go back to my favorite quote from Aristotle, that movement is life. And people with persistent pain tend not to move to protect, guard, and not feel more pain. But it can set the stage in a chronic situation, not an acute, and I always want to make that distinction. I'm not talking about somebody who just come out of surgery or a day after a major injury. This is for people with persistent pain. This issues of the fear anxiety model. The other thing is that, you know, when people don't move, they can't confront some of the benefits of movement, some of the benefits of range of motion or burning calories, possibly losing weight. They become separate from that, and that ends up perpetuating the maladaptive behaviors and pain situation. Okay, looking at kind of the time here, we talked this slide. I really just wanted to kind of drive the point home that hurt doesn't equal harm. In life, we're going to hurt, but a lot of people will equate that with harm. I had a lady the other day tell me that, and she'd been in pain for 2.5 years. She said, you know, I still have pain, and therefore I haven't healed, because once I heal, I won't have any pain. So you could see her thinking. In part, some of that makes some sense, but after 2.5 years, the healing process has taken place. And now this belief is going to perpetuate her deconditioning and dysfunction, anxiety, and fears of re-injury. So again, taking a look at what people believe and their ideas about pain are extremely important in the treatment of people with persistent pain problems. What else? Here's some ideas. You know, the belief that pain is uncontrollable. People that take passive attitudes to rehabilitation. We talked before about, you know, medical focus is appropriate for an acute injury, but once acute pain moves to persistent or chronic pain, we have to gently try to help the patient shift thinking from a very passive role where you do something for me, doctor, and take it away, to what do I need to learn to do to help myself get better. And the idea of being fixed and cured of my pain is perhaps not very realistic. So there are behaviors that can lead to anxiety, fears of re-injury, and deconditioning, and risks for perpetuating pain. Extended use of downtime, staying in bed, not getting up, not moving again, big issues. So you'll want to ask also, in my interviews, I asked the questions about what does pain stop you from doing that otherwise you'd like to be doing? And then I ask it in a different way. I say, if the old you was this active of a person, it would be safe to say that you're below this level. And everybody, 100% of people say absolutely. So then I get them to give me an estimate. Say, 100% less your old self, 50%, 75, 25. And I get an idea of what they see this drop in activities is, to kind of use that as a starting point. And then kind of make the observation that what we're going to try to do is reduce that interference as much as we can. But to do it in a very paced manner, where nobody gets pushed, which then can kind of foster more fears of re-injury, but a gentle kind of a graded increase in activities. This is the foundation, that idea of the functional restoration program model that we have in terms of dealing with people with persistent pain. A model, by the way, that has been shown through research to be very effective. You get people to start moving. And a critical part of that is my colleagues, physical therapists, who are on the front lines of helping people confront their fears and their pain. Okay, that's behaviors. People that say, that use, high pain ratings may be an indicator of somebody that's got anxiety and fears of re-injury. People that use excessive reliance on aids, crutches, are an indicator of some risk that we may need to be looking at. I think we're going to talk in a future echo talk about sleep and how sleep is affected by pain, which is also an energy management function. Sleep quality is also impacted by pain. And you can see some of the other behaviors that are problematic. Because I do a lot of workers' comp, I see people that may, because of the injury, end up being inadvertently rewarded for not going to work. And behaviorally, that can be a huge factor in terms of addressing with people, and can also add to anxiety and fears of re-injury. So I won't get into all of these points, but just the idea that there may be, the systems may be set up to actually punish wellness, punish movement in life. Other categories of risk. I put this slide in just to, kind of identify, the lack of satisfaction with previous treatments for pain, the language we use in terms of our diagnosis may all be factors that could set the stage for increasing risk of anxiety and fears of re-injury. Okay. Again, emotions. We were talking about fear of movement, stress, being unable to. The other biggest thing I see is people will say they don't feel like they have control of their life anymore as a result of this. And another big issue is blame, a sense of injustice due to the pain problem. I invite you all to ask the person, what is the reason for their pain? Was it the fault of somebody else? Was it an accident? Or was it just simply nobody's fault? That can be a huge factor in terms of their expression of pain and what you're going to be working with. So another risk factor. Families can impact the person's anxiety levels. A very solicitous spouse is a wonderful thing in the very beginning of an injury because it shows that he or she cares. Over time, that solicitous behavior can actually reinforce fears of re-injury, deconditioning, because honey, you don't have to take the garbage out. I'll do that for you because I love you. Yeah. And now we're doing less and less and less. So looking at how families can impact anxiety and fears of re-injury is also, I think, an important area. Again, how to identify a person at risk? It's the second point. I put 2 stars, avoidance. When you see high avoidance numbers, we've got some problems, and that's somebody you want to pay attention to. Okay.
Just another couple minutes.
Yeah. Okay. Who are people at the highest risk? You can see a list here of some of the issues that may do that. And I think what I want to do is end at this point. I've got through most of my slides. I think the point is made. And I wanted to, if I could, go back to a metaphor. And forgive me for really milking this metaphor, but I'm going to do it anyways. My metaphor is my ping pong ball in my jar. And I'll leave you with this note. that in the sense, in the past, I've talked about this representing pain, okay? But this can also represent suffering. And I think what anxiety and fear of re-injury is really looking at is worries and suffering. So what we tend to see when people come to see us, their suffering component also affects their lifestyle. And many people feel like this with their pain problem. And this represents not only pain, but it can also represent suffering. And what I've learned is that addressing the suffering is very important. Equally important, though, is addressing how this person is shrunk down to the size of this jar. And much of the therapies that Paul and I are involved in, I think, if I could sum it up in a sentence or two, is helping people move from this size life to this size life. And you can see that that suffering is still possibly part of their life, but with a bigger life, the suffering is seen quite differently.
Yeah.
So the goal is to move someone from this to that.
Perfect.
And I think the team approach, the interdisciplinary model really works towards doing this. So forgive me for milking my metaphor once more, but I hope it drives home a point. I hope it reinforces a point.
Yeah, it's a great one. Thanks, Dr. Lewandowski. So we'll wrap up for the day. Just a couple of quick announcements about our next session coming up. Just a second here, let me get my screen pulled up. So we're going to be hearing from Dr. Cole, who you saw today. He's going to be talking about mental health implications of pain on March 4th. And then we'll get into the role of spinal cord stimulation and pain pumps for the treatment of chronic pain. And then we're actually going to be switching up that topic for April 1st is going to be SBIRT, so screening, brief intervention, and referral to treatment. Paul's going to be handling that one. But in the meantime, please don't hesitate to reach out to us, submit your cases. Jake, I'll be following up with you. It looks like Dr. Dalton took off, but I'll follow up with him as well. Don't forget to submit your evaluation form to claim CME credit for today. So that's just this link here underneath today's date, online evaluation CME form on our Echo Clinic webpage. And one other item I wanted to mention is that we're going to be launching a what we're calling our Project Echo Nevada Resource Library. So if you've ever visited our video recordings page here, we know it's pretty hard to navigate, kind of hard to find stuff if you're looking for a specific topic that you missed and you wanted to watch again. So we're actually going to be developing this web page a little further to make it easier to navigate. So there's going to be a search function, filters, and all that kind of stuff. So you can, find the videos and find the recordings of the Echo Talks that most interest you. So we'd like to get your feedback on that. So I'll send out a link through the chat box right now for a survey that we're asking you to complete to share your feedback there. So thanks everybody for joining today. Hope to see you next time. Again, March 4th, we'll be back. Have a good day.
Thank you.